Good afternoon, everyone. Thank you for joining us for this discussion on ensuring Medicare's sustainability. I'm Bill Hoagland here with the Bipartisan Policy Center, and I have the pleasure to work with our health staff here, led by Marilyn Serafini, along with our health policy director, Oliver Kim, the staff here, and an expert advisory group. We have been engaged in a review of the Medicare program and its long-run sustainability. The Medicare program, as many of you know, was signed into law in 1965 to provide health coverage and increased financial security for older Americans and people with disabilities who were not well served in the insurance market characterized by employment-linked group coverage. On a personal note, I graduated from high school that year, 1960. I'm an old guy. That's 58 years ago. And today I am one of the 65 million Americans who benefit from this critical and important program. Over the years, it has evolved from hospital and physician services, Part A and B insurance, to include the option in 1985 for individuals to enroll in risk-based private health plans. Part C it was called, or Medicare Plus Choice later. It's been relabeled to Medicare Advantage. And then in 2003, Part D, prescription drugs, were added, as with the Medicare Modernization Act. And most recently, of course, there was some reforms in the Inflation Reduction Act. That growth of this program, of course, comes with a cost. Nearly $1 trillion this year is estimated by CBO yesterday, second only to Social Security as the largest program in the federal budget. I also note that the CBO report yesterday projects that the program's costs will increase at an annual rate of about 7% over the next 10 years, while beneficiary growth will be from 65 million to 77, or about 2%. In other words, on a per capita basis, the program is still growing will be growing at about 5% annually. I go through this history that most of you already know and the recent numbers simply to point out how this program has grown and evolved, just as science, medicines, treatments, and the medical profession has evolved over the last 60 years, but always with the goal of providing quality, affordable health care to our senior citizens and others who qualify. We know Medicare and its future has been much in the news lately, from the State of the Union address last week to even advertisements at the Super Bowl. At the outset, I want to be clear. The Bipartisan Policy Center staff do not believe that the future of Medicare should be tied in any way to raising the statutory debt limit later this summer. At the same time, however, we acknowledge that the program faces cost and financing challenges that should be addressed by Congress in order to ensure its sustainability for current and future senior citizens and peoples with disability. The 2022, last year's annual report of the trustees of the Federal Hospital Insurance Fund predicted that that fund would deplete its reserves by 2028. We will see what their report says, hopefully later this spring when they update it again. But yesterday, CBO issued its annual report and now estimates that the hospital fund will deplete 5 years later in 2033, largely because I believe from their estimates, it is due to increased payroll taxes that will provide additional revenues to the fund. While the HI Part A trust fund depletion is one aspect of the program's financial status, it should not be the only issue of focus. This was a reprieve, if you like, for the maybe 10 years before we have to face that again. I think should be an opportunity to look more broadly at the program. Are the tools available for beneficiaries to make informed coverage decisions? Can we simplify Medicare fee-for-service to provide predictable cost-sharing obligations? Could Part A and B, and maybe even D, be combined into a simplified program to simplify and make this complex administrative processes more easy for beneficiaries and providers? Can price competition in both the fee-for-service and the Medicare Advantage programs be enhanced to ensure fiscal sustainability while maintaining, if not even expanding benefits? Can a bipartisan agreement even be reached in the long term that doesn't envision some form of increasing revenues. Joining me shortly are 4 health policy experts to address these and other questions, and time permitting your questions. So submit your questions using the live chat function on your YouTube or via Twitter using hashtag BPC Live. We will also encourage you to engage with our Twitter handle at BPC Bipartisan. But before we turn to the panel, I want to recognize our partner for this webinar, Arnold Ventures. We are joined by Erica Sacher, VP Health Policy, Arnold Ventures, and a health policy expert in her own right, having served both at OMB and CBO and Brookings previously. So Eric, over to you. Erica?
So great. Thank you, Bill. And thanks to all of you for joining today. So as Bill said, I'm Erica Sacher, and I work at Arnold Ventures, which is a philanthropic organization that's focused on addressing pressing domestic policy problems. And for us in the healthcare space, this includes making healthcare more affordable for families and patients, for businesses, and for taxpayers. So we're here today to talk about Medicare, which, as Bill noted, provides healthcare coverage to more than 60 million Americans. The Medicare program is really popular, and the overwhelming majority of Medicare beneficiaries are happy with their coverage. But at the same time, the program is not working as well as it could be, and Bill highlighted a couple of the reasons why this is the case, and it faces significant fiscal challenges that policymakers will have to deal with. One sign of this is the impending insolvency of the Hospital Insurance Trust Fund. But just to emphasize one point that Bill made, the Hospital Insurance Trust Fund, that really represents just one slice of the Medicare program. When we look across the program as a whole, it's apparent that Medicare faces fiscal challenges due to the aging of the population. We have more people that are becoming eligible for Medicare over time, but also due to rising healthcare costs, which make it more expensive to provide care for each beneficiary. The people that are really footing the bill for the high spending in the Medicare program are beneficiaries and taxpayers. Beneficiaries are facing higher out-of-pocket costs, and this includes higher Medicare premiums that they're paying. But the fiscal situation is also putting increasing pressure on the federal budget, and it's limiting our ability to fund other priorities that Americans might care about. So the question then is what policymakers can do to improve the sustainability of the Medicare program. There are really 2 fundamental options. We can spend less, or we can raise additional revenue to pay for the program. I think from our perspective on the spending side, one good place to start is by identifying places where there's waste, fraud, and abuse that is driving up spending, or places where the Medicare program is currently overpaying. These really represent opportunities to improve the program without harming beneficiaries and lowering their costs. We are all here at this event today because we care about the Medicare program and we care about making it stronger. And one critical part of that is being a good steward of Medicare dollars and making sure that we're demanding better value for the amount that we're currently paying. So I realize that's easier said than done, and then enacting reforms to Medicare is politically challenging and it's going to involve making trade-offs. But the problem is not going away, and the problem will only get harder and more costly to fix if policymakers wait to act. To get to meaningful reforms, we need to be able to have a dialogue about what's working that we should protect and where the program isn't delivering enough value to beneficiaries or to taxpayers. That's what we're trying to do with our work here at Arnold Ventures and with our work with BPC on this issue. We're trying to help support that conversation by generating evidence about how the program is working and what the impacts of reforms might be. We think a real conversation about this issue has to be grounded in the facts. And then on top of that, we're also supporting policy development, we're supporting education and technical assistance to help policymakers and stakeholders identify and advance viable solutions. I hope that the conversation today gives you a better sense of the policy debate around Medicare. And I also hope that you're able to walk away with a better understanding of potential reforms that could help strengthen the program for beneficiaries now and make it more sustainable for the long term. And with that, I'll turn it back to Bill. I'm looking forward to the panel discussion.
Thank you, Erica. It's a nice setup here, and thank Arnold Foundation for that. Arnold Ventures for its support of our work here. It's a pleasure working with you and your team. I'm going to introduce our 4 panelists individually. in alphabetical order, no preference here, just in alphabetical order. And I'm going to ask, as I introduce them, I'll ask them to they can tell a little bit about themselves. But I'm going to ask them in their opening comments to address the exchange, if you like, between the president last week at the State of the Union address and Congress that concluded that Medicare was off the table, I believe, in any discussion surrounding the debt limit increase. As I said in my opening comments, we at BPC clearly do not think we should link increasing the debt limit to Medicare reform at this point. So I just asked each one of them, do you agree in your opening comments that Medicare is off the table for any reform? So our first panelist, Daisy Inequigi, I messed that up. I'm sorry, Daisy, again. But Daisy is an operating partner, Welsh, Carson, Anderson, and Stowe. So Daisy, take it away.
Thank you very much, Bill, and thank you to the Bipartisan Policy Center for facilitating this conversation and getting us to talk about something I, as a budget geek, still, I feel like we should continue to talk about. Bill, I think your question is well taken because it was a great theatrics on a very serious policy matter at the State of the Union, and I personally agree with you that and the Bipartisan Policy Center that discussions, major policy discussions, especially about an entitlement program like Medicare, should not be linked to raising the debt ceiling. I do think, however, that as you mentioned in your opening comments, we've got major entitlement, mandatory spending programs that are largely driving the federal budget. And the only group really set up in our government to make policy on such matters is the US Congress. So as a matter of just exercise for me, I mentioned this to Bill before we started, I went back and looked at the Congressional Budget Office's Budget and Economic Outlook from 2003 through 2011. Ellen Hayes and I were the lead authors of Chapter 1, the Budget Outlook. And, shocking sort of revelation, I'd forgotten this, but we had a $5.6 trillion surplus, budget surplus at the time. And that was at the tail end of the Clinton administration. The very beginning of the Bush administration, a couple of things occurred. One major one was legislation to provide tax relief, and that was a $4 trillion coster over 10 years. Why do I say that? Because we spent time explaining why the surplus is now 1.6 trillion as opposed to 5.6. Fast forward to this year, it's 20 years experience, and we've got major deficits, serious debt, all of which are putting a lot of pressure on the federal budget, and Medicare, Medicaid, Social Security, as well as discretionary spending, so defense and non-defense, are all part of that picture. So it does this, I think this is a reminder that it matters who we elect. We need a Congress that can engage on very serious policy matters that require decisions that are difficult, because these are huge programs. And, Medicare is part of that equation. And I think hopefully my fellow panelists agree with me, but as hard as it is, I do think it necessitates serious engagement.
Thank you, Daisy. Josh Gorton. Josh is Director of the Health Policy of the Committee for Responsible Federal Budget. So Josh, what's your thoughts? Opening remarks.
Well, thanks for having me. I'll give my remarks, not as just the Director of Health Policy at Committee for Responsible Federal Budget, but I also lead our Health Savers Initiative and our Trust Fund Solutions Initiative. So all those things combine to where I spend a lot of time thinking about questions like this. And when I think about Medicare, the first thing I think about in terms of its costs is that right now we spend about 3.7% of GDP on Medicare, and that's going to grow to about 6.7% of GDP by 2050. And that's under a pretty conservative assumption. The Medicare trustees have some alternative scenarios that have it going a little bit higher than that. And when I think about that difference, that 3% of GDP difference, it often doesn't sound like a large amount, but that's about the size of the current Defense Department. So over the next 30 years, we're adding basically an entire new Defense Department onto the federal budget just to pay for this one program. And obviously other programs of the federal budget are projected to grow as well. So we have this large growing program. It's growing in part because of the aging of the population, but it's growing mainly because healthcare costs grow faster than the economy, and that is a system-wide problem. So when I think about should Congress take this off the table, I say, of course not. This is a big problem. Congress and the president have to do something about it. I agree that it doesn't have to be tied to the debt ceiling. That's a different issue, which I think we'll get to a little bit later. But really, Congress and the president's job is to deal with these large national problems and try and do something about it. Furthermore, we know that the healthcare system can be improved. No one out there is saying it's perfect. We spend a lot more than every other developed country. Our outcomes are not nearly as good. So yeah, we should do something about it. We can make Medicare more efficient. We can reduce costs. I think there can be a disagreement about what the word cut actually means, but that is just semantics. This is the business of the country. And so I think Congress and the president should always be working towards making our healthcare system more efficient, making Medicare work better for beneficiaries, and ultimately figuring out a way to have it cost less or grow less quickly over the long term. And the one other thing I would say is that the Hospital Insurance Trust Fund, as you said, is going to become insolvent in the next decade. This means that Congress and the president are going to have to pass at least one piece of legislation on Medicare over the next decade. I would want that piece of legislation to be carefully thought out, do so in a way that reduces healthcare costs, not just fixes this one small accounting trust fund issue. And so I'm always working towards convincing members of Congress and the public and the media that this is something that we should get to work on sooner rather than later.
Thank you, Josh. And I'm turning it now to Harriet Komisar. She's a senior strategic policy advisor at AARP, Public Policy Institute. So Harriet, your thoughts and opening comments.
Okay. Hi, yes, yeah, thank you. Hi, everyone, and thanks. It's great to participate in this. And I appreciate the BPC holding this panel on this tremendously important topic, because this is a tremendously important program. Nearly 1/5 of Americans get their health insurance from the Medicare program. And all of us look forward to having Medicare be our health insurance in the future. So I absolutely agree that Medicare should not be tied to the debt limit discussions. That said, I think Medicare should have its own separate table where discussions of Medicare improvements are taken up, and the focus should be on improvements. There's always room for improvement, as other panelists have said. For example, the major prescription drug reforms enacted last year that will make medicines more affordable for individuals and save Medicare money. Thoughtful improvements to Medicare take time to develop, discuss, phase in, so we shouldn't ignore Medicare or waste time. And in considering Medicare reforms, the focus needs to be on the people Medicare serves and ways to ensure that the program works well for them, as well as ways to keep the program strong for future generations. And I just want to add one other piece of perspective. The program, as others have said, the program is growing both because the number of people in the program is expanding and because healthcare costs continue to grow faster than general inflation. And as a result, the program is going to be representing a greater part of GDP. So each of those, it's important to keep in mind each of those factors. So when it comes to the growing population, we should think about how that cost of that should be shared across society. It's a good thing we have an aging population and that there's more longevity. And then, as Joshua said, when it comes to healthcare costs growing more rapidly than inflation or the economy as a whole, that's a system-wide problem, and there's so much improvement that we could do there. And then one other piece of perspective is that although Medicare is expected to grow as a percentage of GDP, GDP is also growing. Like, we're going to have a lot more resources. So we could think about whether a bit more of that should go toward health insurance in this very valuable program. Just putting that out there as some perspective. So thanks.
Thank you. Thank you, Harriet. And last but not least, Josh Trent. He's a principal at Levitt Partners. Levitt will sound familiar, former Secretary of Health and Human Services, Mr. Levitt. So Josh, your thoughts.
Bill, thanks for having me, and thanks to my colleagues for the opportunity to join them for the discussion today. Happy to offer a couple of thoughts in response to your question. I'll do that as a former staffer and former administration guy, not representing necessarily current firm views or client views. Yeah, you ask an important question. Should Medicare be off the table for Congress to kind of consider? And I think if you look at the number of bills that members of Congress have introduced to make changes to Medicare, kind of across the board, spending increases, spending reductions, benefit increases, benefit changes, financing structure changes, no financing structure changes. Congress has a lot of ideas on how they want to change and improve Medicare to be stronger for the future. Lots of different ideas there. I do think that Medicare, thinking about Medicare policy, there's great opportunity to not just think about Medicare reform, but about healthcare reform. There's a lot of opportunity for Medicare as a large payer to improve the state of healthcare in the US, because so many other parts of our system follow what Medicare does. We know that nonpartisan experts from Congressional Budget Office to other economists that, all political stripes and of no political stripe at all, do kind of warn us about the future of Medicare and its role in the federal budget and the role of debt and the role that could at some point in the future create an unstable situation for fiscal crisis. We've been through a fiscal crisis. We don't need another one. We know that these are predictable problems. We also know that they're preventable problems. There is no problem from a policy perspective that we can't solve if we get the right people in the room working together in good faith to agree on what the facts are, and then to use that basis of facts and evidence to build trust with one another and work together to put together policies and proposals that can solve it. So we do have a lot of big policy dynamics to think about, but I'm optimistic about the ability of Congress and others in the policy community to think about that carefully and thoughtfully in a targeted way in the future.
Okay. Thank you very much. We'll try to get to a couple of specific questions here, and let me start by trying to get this one out of the way as quickly as possible, not belabor it on this debt limit question. Joshua Gordon, you have looked at this. God forbid we do get to a point where we might, quote, default. What does that mean for Medicare, and if that were to happen?
Well, I mean, the simple answer is that it would be a disaster for Medicare, just like it would be for the US economy and the world economy. Payments for every aspect of medical care for seniors would be disrupted. Hospitals and doctors might not get paid, prescriptions might not get filled, and really everything else under the sun. But I think, that points to the slightly ludicrous nature of the debt limit statute itself, because it conflicts with hundreds, maybe thousands of other statutes that indicate who the government is going to pay, how much the government's going to pay, and at what time. So on the day of default, the government is faced with the choice of either breaking the debt ceiling limit law or breaking a bunch of other laws about who gets paid and when, because it won't have the money to make those payments. And then there's one other little thing I would say is that I've been asked, and maybe 3 or 4 of the viewers might have this question. The Hospital Insurance Trust Fund has some bonds in it, so can Medicare at least use those bonds and not be impacted by the debt ceiling? But it turns out that that's not really the case. The way the Treasury does it is they use very short-term Treasury bonds in order to manage the payments from the Hospital Insurance Trust Fund, and only on regular times convert those Treasury bonds into hospital insurance bonds. So even this is no kind of answer, and the hospital insurance bonds are part of the debt subject to limit. So there's kind of no way out of this. Medicare would have a breakdown just like every other part of the economy and probably the world economy, because US bonds are really the linchpin of stability for economic activity around the world. So it would be all bad.
Thank you, Josh, and I totally agree. This should not happen, and I don't believe it will happen, but it certainly, we're going to have some brinkmanship here over the next many months. Harriet, you and I are old CBO alumni as well as Daisy. Yesterday issued their report, and another cliff. Obviously, there was a thought that the issue of the HI trust fund, separate and apart from anything dealing with the debt, itself would deplete its resources, as was pointed out by Erica, that it's just part A, just one part of it. But tell us, if we ever got to that situation again, if the HI trust fund were to deplete its resources, and now I see CBO has moved that out, we've got some more time maybe. We'll see what the trustees say. What would happen if the HI trust fund actually depleted itself?
Yeah, a great question. So all through Medicare's history, there have been predictions that the Hospital Insurance Trust Fund, which is also sometimes called the Part A Trust Fund, would become depleted. But so far, fortunately, Congress has never allowed that to happen. If it did happen, just to be clear, it would mean that Medicare could not fully pay for the services that Part A covers. So those include inpatient hospital care, some home health care, and skilled nursing facility care. Plus, Part A pays a portion of the payments that go to Medicare Advantage plans. So revenue would keep flowing into the trust fund from the payroll tax, but it wouldn't be enough to fully pay the bills for the Part A services. So as you've mentioned, important thing to remember is Part A is the only part of Medicare that faces this risk of trust fund depletion. The way Medicare financing works, depletion is not a risk for the parts of Medicare that pay for doctors, other clinicians, outpatient hospital care, prescription drugs. Okay, so what if the Part A trust fund ever did run short of funds? The law doesn't say exactly what Medicare should do. So it's a topic of uncertainty and speculation. One possibility is that Medicare slows down paying bills as they come in, because they can only have as much money as the revenue side to pay them. So a backlog would build up, and hospitals, for example, would have to wait longer and longer to get paid. That's maybe a possibility. Another alternative is Medicare might try to cope by only partially paying each bill, for example, paying only 90% of it, roughly. So whatever specific coping method is adopted, the situation will be very disruptive to healthcare and therefore likely to adversely affect patients as well as hospitals and Medicare Advantage plans. Bottom line, it's vital that we strengthen the trust fund and make sure we don't have to face that.
Thank you, Harriet. And so we got the debt limit out of the way. We got the triggering of the HI trust fund out of the way. Now let's talk about what we should do with the program to avoid particularly some of the issues that we just raised. And so Daisy and Josh Trent, and all of you, quite frankly, let's talk about CMS has recently issued some proposed payment updates for the Medicare Advantage program, I believe is one part of it, but other aspects of it dealing with some of it dealing with the what verifying data submitted under for risk adjustment, or the acronym RADV. I'll start with Daisy. Set the framework here, Josh. All of you fill in. What does all this mean? And I guess tongue in cheek, hasn't the president and the administration put Medicare on the table with these regulations? Daisy.
Sure. Let me, permit me a couple of minutes just to tee this up. So the administration, when they came in, this Biden administration last year put out a request for information. So broad in scope, basically asking for feedback from industry, from everyone, for some information around Medicare Advantage. And so that was the signal for, folks who know how this typically goes. That was a signal that there might be some policy changes coming down the pike on Medicare Advantage. The first sort of big policy bill, if you will, was back in December. They put out the marketing and technical changes proposed rule. And a couple of highlights from that: beneficiary protections, proposing a health equity index, marketing guardrails, if you will, so that plans say what they are and are what they say, and a number of other proposals around behavioral health access to care writ large. And so it was a pretty substantial rule, especially for marketing and technical changes. So that was the first tranche. The second is the one you just alluded to, the risk adjustment data validation rule, which came out, finalized actually just last month in January. And in that rule, a couple of important takeaways for the benefit of our audience. They, first of all, will resume conducting audits, of plans and what they submit for payment to the Medicare program. And I'll say a little bit more about that in a second. They also permanently eliminated the fee-for-service adjuster, which was in place to offset any potential recoupments from plans if they were overpaid. CMS had done a couple of studies and basically concluded with empirical evidence, that this was no longer needed as an adjustment. So the audits, back to those, will basically allow CMS, or what CMS is saying that it's finalized, so what they will do is, for every plan, look at 200 or so, medical records, to make sure that there's a reconciliation between information on coding, risk adjustment around each beneficiary, and that there's documented connection between what's been submitted to CMS and what is in the medical record. If they are not consistent, CMS will plan on, what we call clawbacks, or recouping some of those overpayments, and they will do this retroactively, going back to 2018. They could have gone back to 2011, but provided some relief there. The third bucket is the call, I call it the call letter, but basically the advance notice, which is presented to, address risk adjustment, mostly, and several other, it's a huge rule as well, several other technical changes. So it's an update to the risk adjustment model. And this is a model that had not been updated since 2014. CMS basically says there's a proposal. They will build the risk model using ICD-10 codes, not ICD-9. This is a department that moved to ICD-9 back in 2015, but the risk model had not been updated. So that's the first important, proposal. They will also normalize the data in the risk model using 2020 data. Again, because they had not updated this model, the data is quite antiquated from the fee-for-service program. So in doing so, they recognize that certain codes are significantly overbilled. This is an issue in MA writ large. Overbilled codes that could lead to overpayment of plans, again, from the government's perspective, and that there's a need to sort of address some of those overpayments. Again, we've been talking about pressures on the Medicare program. So as stewards of the trust fund, as stewards of the program, Medicare has been interested in, has been under a lot of pressure to do something about Medicare Advantage. There's several other code issues I don't need to get into around what codes were cut, what codes were added. But you can imagine that higher risk scores, if you are younger and just aged into the program, if a plan takes care of more of those patients, they're generally going to do well, again, from early reads. If you have, if a plan has been, let me say, exuberant in how they code, and in using a lot of codes in order to, refine their risk scores, they're going to see perhaps some meaningful changes as a result of this rule. All of this to say, it is these are technical changes, and the CMS is responsible for refining policies that govern these large programs. However, Medicare Advantage is now a $420 billion program. So even small changes can land with significant impact on industry. And as those of us in public policy know, the department is estimating a net effect of 1.03% increase in payments to plans. But there are some that fall on either side of that average. And so this is, I think, creating a lot of interest and study in industry. But from the government's perspective, from CMS's perspective, it is a technical change they are responsible for making, or a series of changes they're responsible for at least proposing in order to be proper stewards of the program. Okay. So I'll stop there so that others can weigh in.
Yeah, can we, with all the four of you, I'm going to change it up here a little bit. We're getting a lot of questions about MA. And I just wonder if Josh and Harriet, if you have any thoughts on the MA. Let me just throw out something here that's been bothering me. What Daisy just mentioned, MA has grown dramatically. And quite frankly, I'm old enough to have been there when we really were putting it together as a program that was designed to create competition and to lower cost long term. And it was, quite frankly, it was a Republican proposal. Now it's about 50% of Medicare recipients are in MA. A study that was just in Health Journal that the MA reimbursement rates are tied to traditional Medicare benchmarks. Once these programs expand, how do you tie it to a benchmark that is for a program that doesn't exist? I just want to get some responses out of all of you, Josh, the two Joshes and Harriet, on the MA program. I like competition. It's good. It's supposed to. Has it worked? I guess is the bottom line. Who would like to take? Go ahead. Josh Trent, you were next in line anyway.
Yeah, so there's a couple different things to say. When you look at the MedPAC data, the preponderance of bids are below fee-for-service rates. And so you raise an interesting question about the bid structure and how that works. There have been proposals in the past from Senator Wyden and other members of Congress to have more kind of competitive bidding of the bids in Medicare Advantage. I think when you look, by lots of different ways to look at how Medicare Advantage is working, one way is to ask the beneficiaries. And when you look at beneficiary surveys, on the large part, they are satisfied. There's always room for improvement. It was said earlier, that's the largest room in the world. It does provide, there's been some really good analysis on the ways that it helps individuals that face social determinants, whether that's transportation insecurity or housing insecurity, food insecurity, and some really creative things that plans are doing. I think when you're thinking about Medicare program at large, there's always room for efficiency. And that's sure, that can be true with Medicare Advantage. It's also true for the other parts of Medicare and for the kind of pieces of Medicare, what Medicare Advantage has to cover. that's one way to look at it.
Josh Gordon.
So I think it's helpful to take a step back, Bill. You were talking about the intention in the beginning was to see if these private insurance companies could come in and compete with each other and in some sense compete with traditional fee-for-service Medicare to see if you could provide health insurance at lower cost.
Right.
And I think the evidence is that they have been able to do that. The budgeteer in me problem is that they've been able to treat patients at lower costs and give additional benefits, but the federal government has not shared in those savings. The plans have basically taken the money for themselves and plowed a lot of that money back into providing extra benefits to seniors. So we have done a lot of research on that. It's pretty clear that MA plans are overpaid relative to fee-for-service. They cost more to treat patients than it would through traditional fee-for-service, and MA plan costs grow faster than costs in the traditional Medicare program on a kind of average per capita basis. So I think it's pretty clear that there's room to at least achieve some savings by reducing the overpayments to Medicare Advantage in ways that won't necessarily harm beneficiaries, especially if you do it slowly and on a targeted basis, the way CMS is suggesting. Now, we've done estimates of what would happen if CMS took stronger action and did some across the board adjustments to have those plan overpayments go away. And that could save hundreds of billions of dollars and help with trust fund solvency. But just these small tweaks to MA payments from CMS seem like the very least we could be doing to make it kind of a more fair fight between MA and traditional fee-for-service Medicare.
Very good. Harriet, I want you to weigh in here too.
Yeah, I'll add a couple of thoughts. First, Bill, so Medicare Advantage has been growing rapidly as a part of the Medicare program. It's approaching 50% of enrollees, but it isn't there yet. And traditional Medicare isn't going away. So even if Medicare Advantage continues to grow, there'll still be predictions say there'll still be a sizable portion, 40 plus to 50% of people will still be in traditional Medicare. And there's a lot of people like traditional Medicare, especially they like the access. With traditional Medicare, you have access to the whole national network of providers and hospitals that accept Medicare, and that's almost all of them. So a lot of people like that flexibility and they like that geographic flexibility. So just want to get that out there. So, at the same time, we really do need to look at better balance between the programs. So while, as Josh was pointing out, the research has shown that Medicare is paying MA plans more than it would cost to cover the same people in traditional Medicare. At the same time, Medicare Advantage plans do offer some financial protections and supplemental benefits that aren't available in traditional Medicare and that people value. So we should work on the balance between these two tracks. And in improving that balance, one thing I like to think about is how do we make traditional Medicare more affordable, and how do we enable people in traditional Medicare to get the same kinds of supplemental benefits that some people in MA now have access to.
And Daisy, I know you wanted to get in here. I want to build on Harriet's last comment. If traditional Medicare is not going away, and I don't think it is, but if we're to make that competitive with the MA plans, do we need to change the traditional Medicare program and somehow provide additional benefits in the traditional that are not to compete with the Medicare Advantage programs? How do we square this circle?
It's a great question, and I'm so glad Harriet brought that up, and Josh Gordon and Josh Trent's comments as well are all very well taken. So we tried to do that in original Medicare. That was, if you remember back when we were talking about the Build Back Better Act a year and a half ago, that was one of the policies that was being contemplated on the Hill. Can we expand coverage in original Medicare, traditional Medicare, to include hearing, vision, and dental. Those extra benefits are table stakes in Medicare Advantage. And we're all accustomed through individual, commercial insurance to having those if we want them. But, that's part of the question. And this is why Medicare cannot be entirely off the table for Congress. Those are questions that we're still wrestling with, Bill. I mean, the other point I was going to add, building on Josh Gordon's point, is, there are a lot of things you can do in MA that are just not, we're not necessarily contemplating in Medicare fee-for-service. So this notion of, risk-based primary care. So go downstream, which the plans are not necessarily doing well, but they have, engaged in contracts with companies that are able to do that well. One thing about public policy is that there are always unintended consequences. And I think that the department, CMS, and administration will certainly hear from folks and should take into consideration what some of the unintended consequences from this rule could be, and think about weighing some of those equities. Because we've said, the department has been pretty forward in saying they want to move Medicare enrollees to value-based contracts so that we can start to take care of patients at risk. That's part of bending the cost curve. So if that is still a vision and a goal, then I think, keeping that sort of at the fore as we examine some of the potential fallout would be smart. But I take my fellow panelists' comments very well.
If for all of you, and Josh Trent to weigh in here, if we, as we're looking at traditional Medicare, is it possible to combine A and B instead of having these two separate programs? Healthcare's moved so far when it was first established. Is there a way to simplify this whole program by just combining A and B together into one program?
Yeah, I think it's fair to say CBO and MedPAC have done a fair amount of analysis on that idea, and a number of committee staff have looked at it over the years. If I recall correctly, it's been several years since I've looked at it, but there's fairly uneven impacts kind of distributionally on the beneficiary population. So, practically one way to think about it might be applying it prospectively. But I think the point that was made earlier, I think Harriet made about the benefit that Medicare Advantage provides and kind of maximum out-of-pocket protection for beneficiaries compared to beneficiaries in just fee-for-service, traditional Medicare alone, it's really substantial. And there's data that MedPAC ran a number of years ago. I don't have updated data. They may have said something more publicly since then updated, but looking at kind of the maximum out-of-pocket protection for beneficiaries, what beneficiary type saves the most on an out-of-pocket basis? Is it Medicare Advantage, traditional Medicare with a supplemental, or traditional Medicare with no supplemental? And it was actually Medicare Advantage, because the Medicare supplemental, those Medigap plans, provided a lot of that first dollar coverage or second dollar coverage, but ended up beneficiaries had to pay for it over time. And that was actually one of the bipartisan reforms in MACRA a number of years ago, is to eliminate new sales of first dollar coverage for Medigap plans because of that utilization that it drew.
And I think a good proposal. We did get a question here, kind of building on the discussion we just had. How do we make sure there aren't negative downstream impacts on the most vulnerable population? I think we do have some special assistance to low income and of course the duals, but how do we avoid the negative impacts on vulnerable populations as CMS works to cut waste, particularly with respect to the proposed rate notice? I'm not sure I understand, but I want to take that.
I understand. It goes back. That's actually the point I was making. My last point. Some of the more vulnerable populations, folks who are, perhaps experience lower socioeconomic status, at times older. Those are the folks who had been perhaps coded with a multitude of diagnosis codes that increased dramatically their risk scores. And so with some of the condensing of the coding, it's a technical point, but let me just walk through that quickly. With some of the condensing of the HCC codes, and the elimination of some of the ICD-10 codes that would have fed into the HCC and then the risk model, that's where there's a potential risk that I think the department has to think through. There may be some downstream effects that might be unintended, because again, it might inadvertently adversely affect some of those more vulnerable Medicare Advantage enrollees who are especially in the risk-based models, particularly for primary care. So it's one that they should probably take a good look at.
We're unfortunately starting to run down on our time here. I want to kind of give each one of you an opportunity, the usual question at one of these roundtable discussions, and that is, if you were king or if you were queen, if you were running this program from the beginning, what would you do? What would be the one or two major changes you would make in this Medicare program that's been in existence for nearly 60 years? That would, first of all, make sure people have access, make sure it has quality care, and yes, reduce the cost to the federal government. What should we do? We can just this discussion, you can understand why maybe new members of Congress and some who are not on Medicare see this as a very complicated and difficult nut to crack, I guess. So we'll go in. Joshua Gordon, you want to go with your thoughts?
Sure, and this is convenient for me because we just released an issue brief on this earlier in the week. I think one of the underappreciated reasons why I think it's foolish to take Medicare off the table is that sometimes when Medicare makes changes, those changes for the better filter through the rest of the healthcare system. And one of the areas we look at is moving to site-neutral payments, where right now Medicare pays different rates for hospital outpatient care versus independent physician office care for kind of the same services that are just as easily done in a physician's office, where it's actually less expensive than doing it in a hospital outpatient department. And if Medicare switched to site-neutral payments, we could save about $150 billion over 10 years, and that could filter through to commercial insurance, also switching to site-neutral payments, which could save between $300 and $400 billion in total national health expenditures, which the federal government also gets some savings from because our tax subsidy for employer-provided health insurance gets less costly, people earn more wages, and we can get more revenue, about $100 billion of additional federal revenue. So this is a great example for why you can still have some savings in Medicare. It can't be considered a cut to a beneficiary, and it can bring more logic and efficiency to the entire healthcare system. So that's kind of the easiest thing I would do if appointed tomorrow.
Before I go to Harriet, but would it be considered a cut, a reduction to the provider?
Well, anytime you save money, someone gets reduced. But the way we think about it is that these site-specific payment differentials have been, over the last decade, encouraging a huge amount of consolidation as hospitals have been buying up physician practices, allowing these large hospital systems to raise prices for all services, not just these simple ones that can be done either in an outpatient or physician's office. So that overall impact of higher prices from basically close to monopoly market power is what everyone considers a market failure and a market inefficiency. And that's something that there used to be bipartisan agreement that the government should step in and do something. So through this small change in Medicare, we could do something about this hospital consolidation, which has been raising hospital prices and healthcare costs across the board for everyone.
Thank you, Joshua. Harriet, what's on your list?
Well, I think it's going to take a whole set of things to make the HI trust fund sustainable and to strengthen the Medicare program. So I like site neutral payments, and I'll add to the set. A starting place for me is with approaches that increase efficiency and value of the program, which site neutral payments would do. And one place that I think about starting is expanding the successful, innovative payment and delivery models that have been being tested in traditional Medicare. Traditional Medicare is, which some people also call original Medicare, is far from static. It's been changing and evolving and trying a lot of new things. So several of the innovative models in traditional Medicare have shown success in controlling costs while maintaining, or better yet, improving quality. One example are ACOs, which are being used, or accountable care organizations, I should say, which are being used in the private sector as well as in Medicare. Another example is Medicare's Independence at Home demonstration program. So in this model of care, people with high needs were able to receive primary care in their homes, leading to more person-centered care, fewer trips to the hospital, high satisfaction among patients and family caregivers, and savings for Medicare. So savings from innovative models like these have been relatively modest so far, but they need time to develop their full potential, and we should keep expanding, evaluating. We should keep evaluating them and expanding on the successful ones. So that's my contribution.
Value-based model. And Josh Trent, what's on your list?
Yeah, I'd say three things. First, the kind of Hippocratic oath, first do no harm. So to Adaze's point about think about the impact of potential Medicare Advantage changes, I think that's really important to think about. We know that Medicare Advantage covers a higher percentage of racial and ethnic minorities than the traditional Medicare. So that's a great point. As far as policy ideas that would reduce spending and kind of be maybe politically tolerable, I think one area of great promise is thinking about care that is of low value. Many of us are familiar with the Choosing Wisely campaign. There's abundant research from medical providers and health economists and researchers and others to say that there's plenty of things that Medicare spends money on that doesn't make anyone better, and in some cases can actually increase the likelihood of patient harm. And when it is medically unnecessarily or kind of extra utilization that doesn't make anyone better, it also just results in beneficiaries facing cost sharing that they need not pay. So there's a couple of different policy ways to tackle that, but I think that's one that is common sense to think about. I think another area that there continues to be great potential on, we've seen past presidential proposals from President Obama in his budget, interest in MACRA. There's more room to go on income-related premiums. We often kind of think of consumers as being off the table, not wanting to charge the beneficiaries more. That's totally appropriate in most cases. But when there are millionaires on Medicare, there is probably room to charge them a little more for their premiums and still respect the kind of basic structure of the program, but to find some efficiencies there.
Thank you very much. Daisy, you have the last word.
I have a few seconds. So I appreciate all the suggestions the panelists, my fellow panelists have thrown out there. Gretchen Jacobson at the Commonwealth Fund and Corey Uccello at the American Academy of Actuaries and I wrote a piece on this last year. And there is no end to the list of potential policy solutions that would get at that best case scenario that you just teed up. Strengthen the program, make it more efficient, sustain the trust fund and keep things moving. But the one thing I will say, the one part that we often don't want to talk about is that too many things are sacrosanct. And every single policy tweak or policy revision you can make in Medicare will leave a huge group of stakeholders very unhappy. So to do real reform, I think we have to set aside the sacred cows. We have to think about all components of healthcare. Again, you said, Bill, if I had a magic wand, I would start from the beginning and think about what kind of healthcare program do I want to see around in 75 years or 100 years, as opposed to how we currently do policy in 6-month increments at this time. So, I think we can have that as the vision with all of the potential policy provisions put forth by my fellow panelists as some going away points.
Thank you. Thank you all. Thank you very much. A lot, we could go on forever. There's lots of issues. We just touched the top of the iceberg, so to speak. I will conclude that there is something that I think we all can agree that should be done and can be done by this Congress, and particularly the United States Senate, which has the confirmation responsibility. And that is, we do have two finally public trustee nominees for the Medicare and Social Security trustees, public trustees. We haven't had that. Those offices have been vacant since 2015. This is just a basic good governance. So the nominees, Tricia Newman and Dimitri Kusevas, we hope that the Senate will move quickly to at least to confirm those positions. We have time now, and we can move forward and get their input. So once again, thank you again, panelists. I appreciate you taking the time this afternoon. The discussion, I'm sure, will continue on about how to maintain and ensure the solvency of Medicare for generations to come. Thank you and good day.
Thank you.